In this lecture, we will discuss AV nodal reentrant tachycardia, including its mechanism, three various types, EKG features, potential causes, clinical significance, and management. Atrioventricular nodal reentrant tachycardia, or AVNRT, is a form of supraventricular tachycardia originating from above the level of the bundle of His. So if you look here, we have our conduction system, right? Here's our sinus node, our AV node here. Underneath it we have our His bundle, or bundle of His. Then we have our right bundle branch, our left bundle branch, as well as the left and anterior and left posterior fascicles that then end with our ventricular Purkinje fibers and innervate our myocardial cells. Okay, so what we have here is that this AV nodal reentrant tachycardia is originating above our His bundle, so in this region here. Okay. Now, AVNRT has been considered one of the most common causes of palpitations in individuals without structural heart disease. Oftentimes, it is paroxysmal, meaning that it'll simply come on suddenly. It has also been shown to be provoked by exertion, coffee, tea, or alcohol. Interestingly, females are more often affected than males. Patients will often complain of abrupt onset of rapid, regular palpitations, as well as possible syncope from a brief drop in blood pressure. If the patient has a history of coronary artery disease, he or she may experience chest pain similar to angina, such as chest tightness around the chest radiating to the left arm or left jaw. Other complaints include anxiety, shortness of breath, and sometimes polyuria due to elevated atrial pressure and the release of atrial natriuretic peptide, okay, or ANP. The rhythm may terminate spontaneously or continue until medically treated. Overall, the arrhythmia tends to be well tolerated and rarely is life-threatening, even in patients with pre-existing heart disease. Okay, so what is the pathophysiology involved with this arrhythmia? Well, AVNRT results from a re-entry circuit in or around the AV node, and this is created by two different pathways. These pathways are referred to as the slow and fast pathways. The fast pathway is typically located anteriorly along the septal portion of the tricuspid annulus, whereas the slow pathway is typically located posteriorly close to the coronary sinus ostium. As a result of these two pathways, a sustained re-entry circuit is created, incorporating the AV node, the His bundle, the accessory pathway, and the ventricle, and as well as the atrium. So as you see here, okay, we have a slow pathway and a fast pathway. The fast pathway is often located anteriorly, and then we have the slow pathway that is located posteriorly. So, okay, so notice here's our atria, just to orient yourself. This is our AV node, that is where our two circuits are occurring. We have our His bundle that then innervate our ventricles. Now, AVNRT can generally occur in three various types, and these three main types of ANRT vary based on the dominant pathways involved, as well as the R to P interval. Now, the RP interval represents the time between antegrade ventricular activation, the R wave, and retrograde atrial activation, the P wave. Okay, so if you look here, our R to P interval, here's our R wave, okay, and then imagine here's a P wave. So that's the R to P interval that can help differentiate some of these. Now remember, the R wave is the antegrade, meaning going towards the ventricles and activating them. So we get the R wave, part of our QRS complex. And then we also have the retrograde atrial activation as it goes upwards and activates our P wave. Okay, so that's what this is the R to P interval that'll help us differentiate some of these. Okay, so this is just simply normal sinus rhythm in this case. Okay, let's take a look at these three main types now. So they include the slow-fast AVNRT, which is also termed the common or typical form. Then we have the fast-slow AVNRT, which is also termed the uncommon or atypical form. And lastly, there's the slow-slow AVNRT. Now, these types are all named based on the antegrade-retrograde conduction pathways. In other words, as we go through them, you will see that the first word represents antegrade conduction, okay, going towards the ventricles, and the second word represents retrograde conduction, going back up towards the atria. Okay, so if you look here, we have three different pathways, or three different types: the slow-fast, the fast-slow, and the slow-slow. Okay, and we're saying that the first word here, so the slow-slow, or the slow-fast, the slow part of it represents antegrade conduction. Okay, so if you look here, this is our slow pathway that would be going antegradely, and then we have the fast pathway. The second part of the word that goes retrogradely, okay? And you'll see this naming is consistent throughout. So we'll start with the common or typical form, the slow-fast AVNRT. And as the name implies, that this is the most common of the three forms. In fact, it accounts for about 80 to 90% of all cases. What we see here is antegrade conduction using the slow AV nodal pathway, and then retrograde conduction using the fast AV nodal pathway, okay? So again, let's just erase some of this so you can see. So again, we have a slow and a fast pathway, and we're talking now about this slow fast, the most common or the typical form. We have a slow pathway that's going antegradely and a fast pathway that conducts retrogradely. Okay, so this is the slow fast form. So imagine we have an impulse that travels down the two pathways. Okay, it will travel down them both. It'll go down the faster pathway and the slow pathway, but it'll go down the faster one faster, just as the name implies, and because of that, it will cancel out the slow pathway's impulse when they meet. So if you look here, okay, we have both, our atria gets an impulse, it comes down, goes down both pathways. The slow, as you can see, conducts slowly, but this fast one is able to conduct all the way around faster, and by the time it gets here, it's able to cancel out the slow's impulse, and it's the fast one that ends up going towards the ventricles, okay? So the fast pathway is the one that's dominating here, and that's what we see normally, okay? Now imagine that there's a premature atrial contraction, or PAC, and because the slow pathway is able to receive an impulse, okay, because it was canceled out, the impulse will travel down the slow pathway. However, it won't be able to travel down the fast pathway because it's still refractory, okay? We said the fast pathway was the one that was able to get around and go towards the ventricles, okay? And because of that, it's still refractory. So we have a PAC, a premature atrial contraction, that's coming earlier than expected, and because the slow pathway is able to receive an impulse, it will go down the slow pathway, okay? So it'll come down, go down the slow, and not be able to go down the fast because of the refractory period that it's still in. Now, by the time the impulse makes it down the slow pathway, the fast pathway will be free to receive the impulse. Therefore, the impulse from the PAC will travel both antegradely to the ventricles as well as retrogradely up the fast pathway. And by the time the impulse makes it back to the start of the fast pathway, the slow pathway will be able to receive an impulse and the reentrant circuit will form. Okay, so again, we have the slow pathway. It's able to come down and not go down this fast pathway. So by the time it gets down to the bottom of the slow pathway, it's able to go back retrogradely because we're no longer refractory in the fast area. Okay, so again, it comes down the slow. By the time it reaches the bottom, where the fast pathway is no longer refractory, and it's able to go back retrogradely up the fast pathway, okay, and as well as travel antegradely. So then, by the time it comes back up to the top of this fast pathway, the slow pathway is ready again to receive an impulse. So again, it will continue down, and you'll see this conduction, all right, how it's coming back at the top. It'll travel both retrogradely as it goes up to the atria, and then it'll come back down through this pathway, go antegradely to the ventricles, and just continue in this circuit around, okay? So again, it was the premature atrial contraction that came when the fast pathway was refractory, so it had to go down the slow pathway, and then that's what set up this reentrant circuit. Hopefully this is starting to make sense. Now on the EKG, the retrograde P wave from retrograde conduction to the atria can be obscured in the corresponding QRS complex, or it may occur at the end of the QRS complex as a pseudo R or R prime wave, or as a pseudo S wave, okay? In other words, the P waves are often hidden or buried within the QRS complexes. If the P waves are present, we may see pseudo R waves, which may be seen in lead V1, or we can see these pseudo S waves in the inferior leads 2, 3, or AVF. The absence of retrograde P waves or absence of pseudo R or S waves results from the very short ventriculoatrial conduction, the time commonly seen in this typical slow-fast AVNRT. In most cases, we will see a typical supraventricular tachycardia appearance with the absent P waves and a narrow complex tachycardia. Okay, so what we're saying here, I know that was a lot, but so we have this circuit going on that's conducting up to the atria into the ventricles, okay? And because it's going up the fast pathway to the atria, okay, and down to the ventricles, we will have a short ventriculoatrial conduction, okay? So going up the fast pathway would be really quick, and remember, our atria is represented by our P wave, or atrial depolarization. And we have our QRS complex representing our ventricular depolarization. Okay, and because of that, if you look here at V1, so this is lead V1 in the slow fast, you can see this area here circled. Okay, notice that. Okay, we have that pseudo R wave that is occurring there at the end of our QRS complex. So it comes down, depolarizes the ventricle, we see this QRS complex, and then goes up this fast pathway to depolarize our atria, and that's why we see that pseudo R wave, okay? Now, oftentimes we don't even see this, so it's buried within our QRS complex because it happens so quickly. Okay, the next type is the uncommon or atypical form, the fast-slow AV-NRT. This accounts for about 5 to 10% of all cases, and what we see here is a fast AV nodal pathway for antegrade conduction and the slow AV nodal pathway for retrograde conduction. This is pretty much the opposite of the typical form. Okay, so now we're on this fast-slow, and in this case we have fast antegrade. Okay, so if we just erase this here, it's pretty much the opposite of what we saw with the slow fast. Okay, now going antegradely, so coming down, we will now have a fast pathway, and going retrogradely, we will have the slow pathway. Okay, we won't go through all the mechanism here, but you can kind of get the idea that we're pretty much seeing the opposite taking place here. Again, usually there's a sudden onset of the arrhythmia that is initiated by a premature atrial contraction, okay, when the other side is still refractory. With this fast-slow AV-NRT, the retrograde P waves will appear after the corresponding QRS complex. In other words, on the EKG, you will see a QRS PT complexes, okay, with the retrograde P wave visible between the QRS complex and the T wave. The presence of retrograde P waves in this form is because the retrograde conduction to the atria proceeds up the slow pathway, and therefore will occur later than ventricular depolarization from antegrade conduction down the fast pathway. Okay, so again, imagine going down the fast pathway towards the ventricles, okay? And because we're going down the fast pathway, our QRS will occur faster than going up the slow pathway where we get our P wave, okay? And because of that, we will have these QRS PT complexes, okay, in which we can see these P waves occurring after our QRS complex. And this is what we see in this fast-slow. So down fast to the ventricles, we see our QRS complex, okay? And then up the slow pathway, which takes a little longer, we see our P waves here afterwards, okay? So notice the P waves are clear in occurring after our QRS complex, okay? Hopefully that makes sense as well. Now, this third type that we have is called the slow AV-NRT, okay? And this is the least common of the three forms, accounting for about 1 to 5% of all cases. It is sometimes confused with orthodromic AV reentry. What we see here is slow AV nodal pathway for antegrade conduction, and then slow left atrial fibers approaching the AV node for retrograde conduction, okay? So instead of this fast-slow or slow-fast, now we have both of them as slow, okay? So we have two slow pathways, so one slow and this other one is slow for both retrograde and antegrade conduction. On the EKG, we will see sudden onset following a premature atrial contraction, just like the others, and then a P wave occurring before the QRS complex. And because the P wave occurs before the QRS complex, it is understandable how this rapid, regular supraventricular tachycardia can be misinterpreted as sinus tachycardia. Okay, so what we see here is this, notice here's our QRS complex. These are our P waves occurring before. And notice how we have regular complexes occurring at a faster rate, all right, with our P wave before our QRS, and it almost appears that this is sinus tachycardia. So you can see how people can often confuse this. Okay, so those are the three types. We had the slow fast, which is the common form, the fast slow, and then the slow slow. All right, let's take a look at the overall EKG features. So in general, the EKG will typically show a tachycardia ranging between 140 and 280 beats per minute with normal and regular QRS complexes. The rate of AV-NRT in children tends to be faster than those in adults. The arrhythmia will start suddenly and is usually initiated by a premature atrial contraction. Now, we've mentioned that the P waves will appear immediately before or after the QRS complexes, or they may be hidden within the QRS complex. A quick way to distinguish these types is by looking for P waves. If there are no visible P waves or pseudo R or S waves present, this is the slow fast type. If the P waves are visible after the QRS complex, this is the fast slow type. And then if the P waves are visible before the QRS complexes, that's the slow type. Okay, so looking at the P waves can help you to differentiate that. Okay. All right, let's finish with the management here. So carotid sinus massage or Valsalva maneuvers, which stimulate the vagus nerve and increase parasympathetic activity, may be effective in terminating AVNRT. Now, other medical therapy options include adenosine, beta blockers, and calcium channel blockers, all of which may suppress the arrhythmia by blocking or slowing the AV node. Amiodarone or flecainide can also be used as a second-line therapy option. Cardioversion is rarely required in these patients unless the arrhythmia is refractory to medical therapy or causing hemodynamic instability. There's also the potential curative option of radiofrequency ablation, okay? And this could be used in patients with frequent attacks for whom medical therapy is not an appropriate long-term option. All right, let's briefly run through our chart here before we end. So AVNRT, or AV nodal reentrant tachycardia, is a supraventricular tachycardia occurring above the His bundle. Remember, it's more prevalent in females than males. Causes: there's physical activity, exertion, coffee, tea, and alcohol, among many others that you can find. The mechanism is due to a re-entry circuit within or around the AV node. And remember, it's that abrupt onset after a premature atrial contraction. We mentioned the three main types, and they're based on the pathways. Remember, the first word represents the antegrade conduction, the second word representing retrograde conduction, okay, as well as the RP intervals, okay. We saw how the R to P intervals vary within each one. So we mentioned the slow fast, or the typical common form that has the slow antegrade and fast retrograde pathways. Remember, in this case, the P waves are not visible, or we can see those pseudo R waves in V1 or S waves in the inferior leads. With the fast slow, or atypical or uncommon form, we have a fast antegrade and slow retrograde. And because of that slow retrograde up to the atria, the P wave will occur after our QRS complex. Okay, so you have these QRS P T waves, meaning the P is coming after the QRS complex and not buried within it. Okay, and we'll see that in V1 or in lead 2, and again, because of that delayed atrial activation. In terms of the last one, the least common one is the slow form, and here we have slow antegrade as well as slow retrograde. In this case, we have the P waves occurring before the QRS complexes in V1 or lead 2, and remember, this can often be misinterpreted as sinus tachycardia, okay, and that we saw how that can be commonly mistaken. Okay, clinically speaking, these patients, remember, this is the most common cause of palpitations with people without structural heart disease. Okay, some can have syncope, chest pain if there's coronary artery disease, shortness of breath, anxiety, polyuria, and this is rarely life-threatening and well tolerated by most patients. We mentioned the management. Again, this is a regular tachycardia, okay, occurring between 140 and 280 beats per minute in adults. Remember, we talked about the P waves that can help us differentiate it. All right, the slow fast, often not visible, or we can have those pseudo R or S waves. The fast slow is after our QRS complex, and then the slow, the P waves will be before our QRS complex. Okay, now in terms of the P to QRS ratio, it could be none or it'll be 1:1. None if it's buried within our QRS complex, as in the slow fast form, or if it's antegrade or retrograde, we can have 1:1 ratio. The PR interval, again, it could be none, short, or retrograde. And again, this does not represent atrial stimulation of the ventricles. Remember, it's originating from here in the AV node, so it's not coming from the atria and conducting down. The QRS interval will be normal, okay? Our conduction, interventricular conduction is normal, so between 70 and 110 milliseconds. There will be no grouping as well as no drop beats. Well, that's the end of this lecture. We discussed atrioventricular nodal reentrant tachycardia, or AVNRT, including its mechanism, 3 various types, EKG features, potential causes, clinical significance, and management. I hope you learned something.